Do you want to successfully complete the D444 Objective Assessment exam? Then you are in the right place. Our website provides a list of questions and answers for your success in the D444 OA exam for free. We understand that acing your OA exam can be quite challenging. That's why we provide completely free exam guides and practice questions for you. In this video, we will cover questions from gastrointestinal disorders, respiratory conditions, infectious diseases, neurological disorders, and eye disorders. So, let's get started. 1. A nurse caring for a pneumonia patient notices yellow sputum production with fever and mental status changes, including restlessness and agitation. Which priority intervention should the nurse implement first to improve oxygenation and respiratory status? A. Encourage fluid intake. B. Administer prescribed antibiotics. C. Position semi-Fowlers upright. D. Give cough suppressants. Can you guess the answer? Correct answer, C. Position semi-Fowlers upright. Explanation. Option C is correct because semi-Fowler's position immediately improves lung expansion and oxygenation, addressing the respiratory compromise that requires urgent intervention before other supportive measures. Option A is incorrect because fluid intake helps thin secretions, but doesn't immediately address oxygenation needs when respiratory status is compromised acutely. Option B is incorrect because antibiotics treat infection over time, but don't provide immediate relief for respiratory distress requiring positioning first. Option D is incorrect because cough suppressants are contraindicated in pneumonia, as they prevent clearance of infected secretions from lungs. Alright, let's break down the core concept behind this question about pneumonia care priorities. When a patient has pneumonia with yellow sputum, fever, and mental status changes like restlessness, they're experiencing impaired gas exchange. The semi-Fowler's position, which means sitting up at a 30 to 45 degree angle, immediately improves lung expansion by allowing gravity to pull the diaphragm down. This creates more space for the lungs to expand, improving oxygenation right away. While fluids help thin secretions and antibiotics treat the infection over time, positioning is the fastest intervention to improve breathing. Remember, cough suppressants are never given in pneumonia because we need the patient to cough up those infected secretions. 2. When assessing a patient with closed-angle glaucoma experiencing severe eye pain and seeing halos around lights, what additional finding would confirm this emergency condition requiring immediate treatment? A. Gradual vision loss. B. Mild eye aching. C. Sudden increased pressure. D. Yellow lens opacity. Do you know the answer? Correct answer, C. Sudden increased pressure. Explanation. Option C is correct because closed-angle glaucoma causes sudden complete blockage of aqueous humour outflow, rapidly increasing intraocular pressure, requiring emergency intervention to prevent blindness. Option A is incorrect because gradual vision loss characterises open-angle glaucoma, not the acute emergency presentation of closed-angle glaucoma. Option B is incorrect because mild aching suggests open-angle glaucoma rather than the severe pain typical of closed-angle crisis. Option D is incorrect because yellow lens opacity indicates cataracts, not the acute pressure crisis of closed-angle glaucoma emergency. To really understand why sudden increased pressure is the key finding in closed-angle glaucoma, let's explore how this emergency differs from open-angle glaucoma. In closed-angle glaucoma, the iris suddenly moves forward like a door slamming shut, completely blocking the drainage angle where fluid normally exits the eye. This causes intraocular pressure to skyrocket within hours, not gradually like in open-angle glaucoma. The severe eye pain and halos around lights happen because the cornea swells from this pressure spike. Without immediate treatment to lower the pressure, the optic nerve gets crushed, causing permanent blindness. This is why closed-angle glaucoma is an ophthalmic emergency requiring immediate intervention. 3. A diabetic patient with tinea pedis presents with scaling between toes and burning after removing shoes. What intervention should the nurse prioritise to prevent fungal spread while promoting healing? A. Apply heating pads. B. Wash and dry feet thoroughly. C. Wear rubber boots. D. Use petroleum jelly. Can you guess the answer? Correct answer, B. Wash and dry feet thoroughly. Explanation. Option B is correct because keeping feet clean and dry, especially between toes, removes moisture that fungi need to grow while preventing spread to other areas. Option A is incorrect because heat increases moisture and creates an ideal environment for fungal growth rather than inhibiting it. Option C is incorrect because rubber boots trap moisture and heat, worsening the fungal infection environment rather than improving it. Option D is incorrect because petroleum jelly creates an occlusive barrier that traps moisture, promoting fungal growth rather than healing. Let's explore why washing and drying feet thoroughly is the priority intervention for tinea pedis in diabetic patients. Tinea pedis, or athlete's foot, is a fungal infection that thrives in warm, moist environments like the spaces between toes. The fungus needs moisture to survive and multiply, so removing that moisture by thoroughly washing and especially drying between each toe creates an inhospitable environment for fungal growth. This is particularly critical for diabetic patients who have reduced sensation and poor circulation, making them vulnerable to secondary infections. While antifungal medications treat the infection, preventing spread requires eliminating the moisture that fungi need to thrive. Heat, occlusive barriers like petroleum jelly and non-breathable materials all create the perfect fungal breeding ground. 4. During an asthma attack, a patient exhibits paradoxical breathing with absent breath sounds and respiratory acidosis. Which medication class should be administered immediately to reverse this life-threatening bronchospasm? A. Beta blockers. B. NSAIDs like aspirin. C. Short-acting bronchodilators. D. Cough suppressants. Do you know the answer? Correct answer, C. Short-acting bronchodilators. Explanation. Option C is correct because short-acting bronchodilators like albuterol immediately relax airway smooth muscle, opening airways during severe asthma attacks with silent chest presentation. Option A is incorrect because beta blockers worsen asthma by blocking bronchodilation receptors, potentially causing fatal bronchospasm in asthmatic patients. Option B is incorrect because NSAIDs, including aspirin, can trigger severe asthma attacks and are contraindicated during acute episodes. Option D is incorrect because cough suppressants don't address bronchospasm and may worsen secretion clearance during asthma attacks requiring bronchodilation. This is a critical concept for the exam, so let's dig into why short-acting bronchodilators are life-saving in severe asthma. When you see paradoxical breathing with absent breath sounds, called a silent chest, and respiratory acidosis, the patient's airways are so constricted that air can't move at all. Short-acting bronchodilators like albuterol work within minutes by stimulating beta-2 receptors in the airway smooth muscle, causing immediate relaxation and bronchodilation. This opens the airways rapidly, allowing air movement and preventing respiratory failure. Beta blockers and NSAIDs like aspirin are absolutely contraindicated because they trigger bronchoconstriction, potentially causing fatal bronchospasm. Cough suppressants won't help because the problem isn't coughing, it's severe airway constriction, requiring immediate bronchodilation. 5. A COPD patient presents with pink skin, pursed lip breathing, barrel chest, and tripoding position. These findings most characteristically indicate which specific type of chronic obstructive pulmonary disease? A. Chronic bronchitis. B. Emphysema manifestation. C. Acute bronchiolitis. D. Pneumonic consolidation. Can you guess the answer? Correct answer. B. Emphysema manifestation. Explanation. Option B is correct because the pink puffer presentation with pursed lip breathing, barrel chest from air trapping, and tripoding position classically identifies emphysema versus bronchitis. Option A is incorrect because chronic bronchitis presents as a blue bloater with cyanosis, productive cough, and peripheral edema, not a pink appearance. Option C is incorrect because acute bronchiolitis is an acute infection primarily affecting infants, not a chronic condition with barrel chest. Option D is incorrect because pneumonic consolidation causes fever, productive cough, and crackles, not the chronic changes of emphysema presentation. Understanding the pink puffer versus blue bloater presentations is essential for COPD management. The pink puffer appearance specifically indicates emphysema, where alveoli are destroyed, causing permanent air trapping. These patients maintain relatively normal oxygen levels by working hard to breathe, which gives them their pink colour. They purse their lips to create back pressure that keeps airways open longer for exhalation. The barrel chest develops from chronic hyperinflation as trapped air stretches the chest wall. Tripoding, where patients lean forward supporting themselves on their arms, helps by fixing the shoulder girdle so accessory muscles can assist breathing. This contrasts with chronic bronchitis patients who appear blue and bloated from cyanosis and fluid retention. 6. Which laboratory values would a nurse recognise as hepatotoxic drug effects requiring immediate medication, discontinuation in a patient taking multiple medications for tuberculosis treatment? A. Low platelets only. B. Elevated AST and ALT. C. Decreased sodium levels. D. High white cells. Do you know the answer? Correct answer, B. Elevated AST and ALT. Explanation. Option B is correct because elevated liver enzymes, AST and ALT, directly indicate hepatotoxicity from tuberculosis drugs, requiring immediate discontinuation to prevent liver failure. Option A is incorrect because low platelets suggest bone marrow suppression or bleeding disorders, not the hepatotoxicity caused by tuberculosis medications. Option C is incorrect because decreased sodium indicates fluid balance issues or CATH, not liver damage from hepatotoxic tuberculosis drugs. Option D is incorrect because elevated white cells suggest infection or inflammation, not the liver enzyme elevation indicating hepatotoxicity. Let's explore why elevated AST and ALT are the definitive indicators of hepatotoxicity from tuberculosis drugs. All TB medications remember the acronym RIPE, rifampin, INH, pyrazinamide and ethambutol, are processed by the liver and can cause hepatocellular damage. When liver cells are damaged, they release their contents, including the enzymes AST and ALT, into the bloodstream. These transaminases specifically indicate liver cell injury, making them the gold standard for monitoring drug-induced hepatotoxicity. Elevated levels mean the TB drugs are damaging liver cells and must be stopped immediately to prevent progression to liver failure. Other lab changes like low platelets or high white cells indicate different problems, but don't specifically show liver toxicity. 7. A patient with metabolic acidosis from diabetic ketoacidosis would present with which characteristic arterial blood gas pattern, requiring immediate intervention to correct the acid-base imbalance? A. pH above normal. B. High bicarbonate levels. C. pH below 7.35. D. Low carbon dioxide. Can you guess the answer? Correct answer, C. pH below 7.35. Explanation. Option C is correct because metabolic acidosis from diabetic ketoacidosis causes pH to drop below the normal range, requiring immediate insulin and fluid resuscitation intervention. Option A is incorrect because pH above normal indicates alkalosis, not the acidosis that occurs with diabetic ketoacidosis metabolic derangement. Option B is incorrect because bicarbonate levels are depleted in metabolic acidosis as the buffer system attempts to neutralize excess acid. Option D is incorrect because low carbon dioxide represents respiratory alkalosis or compensation, not the primary metabolic acidosis of diabetic ketoacidosis. To understand metabolic acidosis in DKA, let's examine what happens to arterial blood gases. In diabetic ketoacidosis, the body can't use glucose for energy due to insulin deficiency, so it breaks down fat instead. This fat breakdown produces ketones, which are acids that accumulate in the blood. As these acids build up, they consume the body's bicarbonate buffer system, causing the pH to drop below 7.35. This is the hallmark of metabolic acidosis, a pH below normal range caused by excess acids or loss of base. The body tries to compensate by breathing faster to blow off CO2, but the primary problem remains the metabolic acid accumulation, requiring insulin and fluids. 8. When caring for a patient with esophageal varices, secondary to portal hypertension. Which intervention is absolutely contraindicated due to high risk of catastrophic hemorrhage? A. Blood transfusion preparation. B. Nasogastric tube insertion. C. Vasoconstrictive medication administration. D. Endoscopic band ligation. Do you know the answer? Correct answer. B. Nasogastric tube insertion. Explanation. Option B is correct because nasogastric tube insertion can rupture fragile esophageal varices, causing massive hemorrhage, making it absolutely contraindicated in these patients. Option A is incorrect because blood transfusion preparation is appropriate and necessary for potential hemorrhage management in variceal patients. Option C is incorrect because vasoconstrictive medications are indicated to reduce portal pressure and prevent variceal bleeding in these patients. Option D is incorrect because endoscopic band ligation is a therapeutic intervention used to treat and prevent variceal bleeding episodes. This question tests a critical safety concept about esophageal varices. When portal hypertension forces blood into esophageal veins, they become like overfilled water balloons ready to burst. These dilated, fragile veins bulge into the esophagus, where any mechanical trauma can cause catastrophic bleeding. Inserting a nasogastric tube would scrape directly against these fragile varices as it passes through the esophagus, potentially tearing them open. This would cause massive hemorrhage that can lead to death within minutes. That's why NG tubes are absolutely contraindicated. In contrast, treatments like vasoconstrictors reduce portal pressure, band ligation treats the varices directly, and blood products prepare for potential bleeding. All appropriate interventions. 9. A celiac disease patient asks about breakfast options. Which food choice would the nurse recommend as completely safe without risk of triggering intestinal inflammation and malabsorption? A. Whole wheat toast. B. Cornflakes cereal. C. Barley porridge oatmeal. D. Rye bread crackers. Can you guess the answer? Correct answer, B. Cornflakes cereal. Explanation. Option B is correct because corn is a gluten-free grain safe for celiac patients, avoiding the intestinal damage caused by gluten-containing grains like wheat. Option A is incorrect because whole wheat contains gluten proteins that trigger autoimmune intestinal damage in celiac disease patients requiring avoidance. Option C is incorrect because barley contains gluten that causes inflammatory damage to small intestine villi in celiac disease patients. Option D is incorrect because rye contains gluten proteins that trigger the autoimmune response, causing intestinal damage in celiac patients. Understanding safe foods for celiac disease requires knowing exactly what contains gluten. Celiac disease is an autoimmune condition where gluten proteins found in wheat, barley, and rye trigger the immune system to attack the small intestine lining. This destroys the villi that absorb nutrients, causing malabsorption and diarrhea. Corn is completely safe because it's a gluten-free grain that doesn't contain the problematic proteins. Cornflakes made from pure corn provide a nutritious breakfast option without triggering intestinal damage. In contrast, wheat toast, barley porridge, and rye crackers all contain gluten proteins that would immediately trigger the autoimmune response, causing inflammation, pain, and further intestinal damage. 10. During Crohn's disease exacerbation with severe diarrhea and right lower quadrant pain, what nutritional intervention would best support healing while minimizing intestinal irritation? A. High fiber diet. B. Large meal portions, ca. NPO with TPN. D. Dairy product increases. Do you know the answer? Correct answer, C. NPO with TPN. Explanation: option C is correct because bowel rest through NPO status with total parenteral nutrition provides nutrients while allowing inflamed intestinal tissue to heal. Option A is incorrect because high fiber increases intestinal motility and irritation during acute Crohn's exacerbations requiring low residue intake. Option B is incorrect because large meals increase intestinal workload when small frequent meals better manage Crohn's disease symptoms. Option D is incorrect because dairy products often worsen diarrhea and cramping and inflammatory bowel disease requiring lactose restriction. Let's examine why bowel rest with TPN is crucial during severe Crohn's exacerbations. Crohn's disease causes transmural inflammation, meaning it affects all layers of the intestinal wall, creating deep ulcers and fissures. During an acute flare with severe diarrhea and pain, any food passing through triggers more inflammation, cramping, and diarrhea. NPO status, meaning nothing by mouth, gives the inflamed intestine complete rest to heal. Total parenteral nutrition delivers all nutrients directly into the bloodstream through an IV, bypassing the digestive system entirely. This provides optimal nutrition for healing, while eliminating all intestinal stimulation. High fiber would worsen inflammation. Large meals increase workload, and dairy often triggers more symptoms. 11. A patient receiving vancomycin develops facial flushing with red rash spreading across chest during infusion. What immediate nursing action prevents progression of this infusion-related reaction? A. Increase infusion rate. B. Stop infusion immediately. C. Administer more vancomycin. D. Apply cold compress. Can you guess the answer? Correct answer, B. Stop infusion immediately. Explanation: option B is correct because Redman syndrome from rapid vancomycin infusion requires immediate discontinuation to prevent hypertension and worsening histamine release reaction. Option A is incorrect because increasing infusion rates would worsen Redman syndrome by accelerating histamine release, causing severe hypertension. Option C is incorrect because administering more vancomycin would intensify the reaction when stopping infusion is the priority intervention needed. Option D is incorrect because cold compresses don't address the systemic histamine reaction, requiring infusion cessation as primary intervention measure. Redman syndrome is a critical infusion reaction you must recognize immediately. When vancomycin infuses too rapidly, it triggers massive histamine release from mast cells throughout the body. This histamine surge causes the characteristic red flushing that starts on the face and neck, then spreads across the chest like a red tide. The reaction can progress to severe hypertension and shock if not stopped immediately. The moment you see facial flushing during vancomycin infusion, you must stop the infusion right away. This halts further histamine release and prevents progression to cardiovascular collapse. After stopping, you can restart at a slower rate. typically over 90 minutes or longer. Never increase the rate or give more vancomycin during an active reaction. 12. Which isolation precaution requires healthcare workers to wear N95 masks in negative pressure rooms when caring for patients with active pulmonary tuberculosis infection? A. Contact precautions only. B. Droplet precautions only. C. Standard precautions only. D. Airborne precautions required. Do you know the answer? Correct answer, D. Airborne precautions required. Explanation. Option D is correct because tuberculosis spreads through airborne particles, requiring N95 masks and negative pressure rooms to prevent transmission to healthcare workers. Option A is incorrect because contact precautions are used for infections spread by direct contact. Option B is incorrect because droplet precautions are used for infections spread by large respiratory droplets, not the smaller particles that transmit tuberculosis. Option C is incorrect because standard precautions are the minimum infection prevention practices, but they do not provide adequate respiratory protection against airborne tuberculosis transmission. Airborne precautions are essential for tuberculosis because of how TB bacteria travel. Unlike larger droplets that fall to the ground quickly, TB bacteria ride on tiny droplet nuclei that can float in the air for hours like invisible dust particles. These microscopic particles are so small they bypass the body's natural defences and travel deep into the alveoli. A regular surgical mask can't filter these tiny particles. You need an N95 respirator that filters at least 95% of airborne particles. The negative pressure room continuously pulls air in and filters it before exhausting outside, preventing TB particles from escaping into hallways. This combination of N95 masks and negative pressure rooms is mandatory for TB patients. 13. Multiple sclerosis patients experiencing muscle spasticity and vision problems should avoid which environmental trigger known to worsen neurological symptoms and precipitate disease exacerbations? A. Temperature extremes exposure. B. Protein intake increases. C. Vitamin supplementation. D. Moderate exercise programs. Can you guess the answer? Correct answer, A. Temperature extremes exposure. Explanation. Option A is correct because temperature extremes, particularly heat, worsen nerve conduction into damaged myelin sheaths, triggering symptom exacerbations in MS patients. See L3. Option B is incorrect because protein intake does not trigger MS exacerbations, and adequate nutrition supports overall health in chronic disease. Option C is incorrect because vitamin supplementation, especially vitamin D, may actually benefit MS patients rather than triggering exacerbations. Option D is incorrect because moderate exercise improves strength and function in MS when avoiding overheating and extreme fatigue levels. Temperature extremes are the #1 trigger for MS exacerbations, and here's why. Multiple sclerosis destroys the myelin sheath that insulates nerve fibers, like stripping the rubber coating off electrical wires. When these exposed nerves encounter heat, even small temperature increases slow down or completely block nerve signal transmission. This phenomenon, called Uthhoff's sign, can temporarily worsen all MS symptoms, including vision problems, muscle weakness, and coordination issues. Even a hot shower or summer day can trigger dramatic symptom worsening that reverses when cooled. Cold can also trigger symptoms by causing muscle stiffness and spasms. That's why MS patients must carefully control their environment, avoiding hot baths, saunas, and extreme weather. 14. A patient with open-angle glaucoma using timolol eye drops reports gradual peripheral vision loss. What additional medication would most effectively lower intraocular pressure? A. Oral prednisone steroids. B. Topical antibiotic drops. C. Acetazolamide carbonic inhibitor. D. Artificial tear lubricants. Do you know the answer? Correct answer, C. Acetazolamide carbonic inhibitor. Explanation. Option C is correct because acetazolamide decreases aqueous humour production through carbonic anhydrase inhibition, effectively lowering intraocular pressure in glaucoma management. Option A is incorrect because steroids can actually increase intraocular pressure, worsening glaucoma rather than providing therapeutic benefit. Option B is incorrect because antibiotics treat infection, but don't address the increased intraocular pressure causing glaucoma vision loss. Option D is incorrect because artificial tears provide comfort, but don't lower the intraocular pressure, causing optic nerve damage. To understand glaucoma treatment, let's explore how acetazolamide works differently from eye drops. Open-angle glaucoma occurs when aqueous humour fluid builds up because it can't drain properly, like a sink with a partially clogged drain. While timolol eye drops work locally to reduce some fluid production, acetazolamide is a carbonic anhydrase inhibitor that works systemically. It blocks the enzyme that produces aqueous humour in the ciliary body of the eye, dramatically reducing fluid production at the source. This dual approach of topical timolol plus oral acetazolamide provides maximum pressure reduction. Steroids would worsen glaucoma by increasing pressure. Antibiotics don't affect pressure, and artificial tears only provide comfort without treating the underlying problem. 15. Post-cataract surgery. Which activity restriction is most critical to prevent increased intraocular pressure that could damage the surgical site and impair healing? A. Reading small print. B. Watching television programs. C. Walking short distances. D. Bending at waist. Can you guess the answer? Correct answer, D. Bending at waist. Explanation. Option D is correct because bending at the waist increases intraocular pressure significantly, potentially disrupting the surgical site and causing serious complications post-operatively. Option A is incorrect because reading doesn't significantly increase intraocular pressure, though eye strain should be minimised during initial recovery. Option B is incorrect because watching television at appropriate distances doesn't increase pressure or strain the healing surgical site. Option C is incorrect because gentle walking is encouraged post-operatively and doesn't increase intraocular pressure, risking surgical complications. Post-cataract surgery restrictions are all about protecting the delicate surgical site, and bending at the waist is the most dangerous activity. When you bend forward at the waist, several things happen simultaneously that threaten the healing eye. Blood rushes to your head, increasing pressure in all blood vessels, including those in the eye. The Valsalva maneuver that naturally occurs when bending increases intraocular pressure dramatically. This pressure spike can rupture the delicate surgical incision, displace the new lens implant, or cause bleeding inside the eye. That's why patients must bend at the knees instead of the waist. Reading and watching TV don't significantly increase pressure, and gentle walking is actually encouraged for circulation. 16. When administering lactulose to a cirrhosis patient with elevated ammonia causing hepatic encephalopathy, what bowel pattern indicates therapeutic effectiveness? A. 1 formed stool daily. B. 2 to 3 stools daily. C. Constipation for 3 days. D. Continuous watery diarrhea. Do you know the answer? Correct answer, B. 2 to 3 stools daily. Explanation. Option B is correct because 2 to 3 bowel movements daily indicates lactulose is effectively removing ammonia through the colon, improving mental status. Option A is incorrect because 1 stool daily is insufficient for ammonia removal, requiring a dosage increase to achieve the therapeutic effect. Option C is incorrect because constipation prevents ammonia excretion, worsening encephalopathy and requiring immediate lactulose dosage adjustment upward. Option D is incorrect because continuous diarrhea indicates excessive lactulose causing dehydration and electrolyte imbalances requiring a dose reduction. Lactulose dosing for hepatic encephalopathy requires precise monitoring of bowel movements. In liver cirrhosis, the failing liver can't convert toxic ammonia to urea, so ammonia builds up and travels to the brain, causing confusion and asterixis, that flapping tremor. Lactulose works by acidifying the colon, which traps ammonia and prevents its absorption, while also causing an osmotic laxative effect. The therapeutic goal is 2 to 3 soft bowel movements daily, because this frequency effectively removes ammonia without causing complications. 1 stool daily means insufficient ammonia removal, while continuous diarrhea causes dangerous dehydration and electrolyte imbalances. The dose must be titrated to achieve exactly 2 to 3 bowel movements for optimal ammonia clearance and mental status improvement. 17. A GERD patient asks about dietary modifications. Which food should be completely avoided, as it relaxes the lower esophageal sphincter, worsening reflux symptoms? A. Lean grilled chicken. B. Steamed white rice. C. Chocolate desserts. D. Baked sweet potato. Can you guess the answer? Correct answer, C. Chocolate desserts. Explanation. Option C is correct because chocolate relaxes the lower esophageal sphincter, allowing stomach acid to reflux into the esophagus, causing heartburn symptoms. Option A is incorrect because lean proteins like grilled chicken are generally well tolerated and don't typically trigger GERD symptoms. Option B is incorrect because plain rice is a bland food that doesn't usually trigger acid reflux and can help absorb stomach acid. Option D is incorrect because sweet potatoes are not known to trigger reflux and provide beneficial nutrients. GERD dietary restrictions focus on foods that relax the lower esophageal sphincter, and chocolate is a triple threat. Chocolate contains 3 compounds that worsen reflux: methylzexanthine, which directly relaxes the LES muscle, caffeine, which stimulates acid production, and high fat content, which delays stomach emptying. When the LES relaxes, it's like leaving a door open between your stomach and esophagus, allowing acid to flow backward, causing heartburn. This is why chocolate consistently triggers symptoms even in small amounts. Lean proteins like chicken don't affect the LES, plain rice is actually soothing, and sweet potatoes are alkaline vegetables that help neutralize acid. But chocolate must be completely eliminated from the GERD diet. 18. During acute anaphylaxis with respiratory distress and hypertension, what medication must be administered first before any other intervention to reverse this life-threatening reaction? A. Diphenhydramine, antihistamine. B. Methylprednisolone steroid. C. Epinephrine autoinjector. D. Albuterol nebulizer treatment. Do you know the answer? Correct answer, C. Epinephrine autoinjector. Explanation. Option C is correct because epinephrine immediately reverses anaphylaxis by constricting blood vessels, relaxing airways, and stabilizing mast cells, preventing cardiovascular collapse. Option A is incorrect because antihistamines work too slowly for an anaphylaxis emergency, which requires immediate epinephrine to prevent death. Option B is incorrect because steroids prevent biphasic reactions but do not reverse acute anaphylaxis, which requires epinephrine as first-line treatment. Option D is incorrect because bronchodilators address wheezing but do not reverse systemic anaphylaxis, which requires epinephrine for cardiovascular stabilization. Anaphylaxis treatment has one absolute rule: epinephrine first, always. During anaphylaxis, massive histamine release causes blood vessels to dilate and leak fluid, dropping blood pressure while airways swell shut. Epinephrine is the only drug that reverses all these life-threatening changes simultaneously. It constricts blood vessels to restore blood pressure, relaxes bronchial smooth muscle to open airways, and stabilizes mast cells to stop histamine release. This must happen within minutes or the patient dies. Antihistamines like diphenhydramine work too slowly, taking 30 minutes when you have only minutes. Steroids prevent later reactions, but don't reverse acute anaphylaxis. Bronchodilators only address breathing, not the cardiovascular collapse. Remember, EPI first, EPI fast, EPI saves lives. 19. A patient with Huntington's disease exhibits chorea movements and cognitive decline. Which medication specifically targets the excessive involuntary movements characteristic of this condition? A. Levodopa dopamine precursor. B. Tetrabenazine movement reducer. C. Cholinesterase inhibitor drug. D. Selective serotonin reuptake. Can you guess the answer? Correct answer. B. Tetrabenazine movement reducer. Explanation. Option B is correct because tetrabenazine specifically reduces chorea by depleting dopamine, targeting the excessive involuntary movements characteristic of Huntington's disease. Option A is incorrect because levodopa increases dopamine, worsening chorea movements when Huntington's already has excessive dopamine activity present. Option C is incorrect because cholinesterase inhibitors treat Alzheimer's dementia, not the movement disorders characteristic of Huntington's disease pathology. Option D is incorrect because SSRIs treat depression, but don't address the chorea movements requiring specific dopamine depletion therapy. Huntington's disease creates a unique movement disorder that requires specific treatment. In Huntington's, genetic mutations cause excess dopamine activity in the basal ganglia, leading to chorea, those uncontrollable dance-like movements that worsen over time. Tetrabenazine specifically targets this problem by depleting dopamine from nerve terminals, essentially turning down the dopamine volume that's causing the excessive movements. It's the only FDA-approved drug specifically for Huntington's chorea. Levodopa would be disastrous because it increases dopamine, making movements worse. Cholinesterase inhibitors treat Alzheimer's memory problems, not movement disorders. SSRIs help with depression, but don't address the motor symptoms. Only tetrabenazine directly reduces the choreiform movements that define Huntington's disease. 20. HIV patients with CD4 counts below 200 require which specific preventive measure to avoid opportunistic infections while immunocompromised? A. Increased sun exposure. B. Fresh fruit consumption. C. Neutropenic precautions isolation. D. Vigorous exercise programs. Do you know the answer? Correct answer. C. Neutropenic precautions isolation. Explanation. Option C is correct because CD4 counts below 200 indicate severe immunosuppression, necessitating precautions like avoiding crowds and potential infection sources. Option A is incorrect because sun exposure does not boost immunity, and HIV patients often require sun protection due to photosensitivity. Option B is incorrect because fresh fruits may harbour bacteria that are dangerous for immunocompromised patients. They should avoid raw foods. Option D is incorrect because vigorous exercise can further suppress immunity. Gentle activity is better for maintaining health without overtaxing the system. When CD4 counts drop below 200, HIV progresses to AIDS with severe immunosuppression, requiring protective isolation. CD4 cells are the helper T cells that coordinate the entire immune response, and below 200 means the immune system is essentially non-functional. These patients are vulnerable to opportunistic infections that healthy people easily fight off. Neutropenic precautions become essential: private rooms to avoid exposure, no fresh fruits or flowers that harbour bacteria, avoiding crowds where pathogens spread, and careful hand hygiene. Fresh fruits seem healthy but can carry bacteria like listeria that are deadly to immunocompromised patients. Sun exposure doesn't boost immunity, and vigorous exercise can further suppress the immune system. The focus must be on protection from infection through strict isolation protocols. 21. Which finding in a pneumonia patient indicates development of pleural effusion requiring immediate thoracentesis to prevent respiratory failure? A. Productive yellow cough. B. Dull percussion sounds. C. Fever above 100. D. Fine crackle sounds. Can you guess the answer? Correct answer, B. Dull percussion sounds. Explanation. Option B is correct because dull percussion sounds indicate fluid accumulation in pleural space, preventing lung expansion, requiring drainage to restore respiratory function. Option A is incorrect because productive cough indicates pneumonia, but not the specific complication of pleural effusion requiring thoracentesis. Option C is incorrect because fever indicates infection, but doesn't specifically suggest pleural effusion complication requiring immediate drainage intervention. Option D is incorrect because fine crackles suggest pneumonia infiltrates in lung tissue, not fluid accumulation in pleural space. Let's dive into recognizing pleural effusion complications in pneumonia patients. When pneumonia spreads to the pleural space, fluid accumulates between the lung and chest wall, creating what we call a pleural effusion. This fluid acts like a barrier preventing the lung from fully expanding during breathing. The key diagnostic finding is dull percussion sounds because fluid doesn't resonate like air-filled lung tissue does. When you percuss over fluid, it sounds dull like tapping on a jug of water versus the normal resonant sound of tapping on a drum. This finding, combined with dyspnea and decreased breath sounds, indicates significant fluid accumulation, requiring thoracentesis to drain the fluid and re-expand the lung. Without drainage, respiratory failure can develop. 22. A myasthenia gravis patient taking pyridostigmine develops excessive salivation, muscle twitching, and abdominal cramping. Which antidote reverses this cholinergic crisis? A. Epinephrine injection. B. Atropine administration. C. Naloxone reversal agent. D. Flumazenil antagonist. Do you know the answer? Correct answer. B. Atropine administration. Explanation. Option B is correct because atropine blocks excessive acetylcholine effects from pyridostigmine overdose, reversing cholinergic crisis symptoms, including salivation and cramping. Option A is incorrect because epinephrine treats anaphylaxis and cardiac arrest, not cholinergic excess from myasthenia gravis medication overdose. Option C is incorrect because naloxone reverses opioid overdose, not the cholinergic crisis from excessive pyridostigmine in myasthenia patients. Option D is incorrect because flumazenil reverses benzodiazepine overdose, not acetylcholine excess, requiring anticholinergic antidote therapy with atropine. Understanding cholinergic crisis in myasthenia gravis is crucial for patient safety. Myasthenia patients take pyridostigmine to increase acetylcholine at the neuromuscular junction, improving muscle strength. But too much pyridostigmine causes cholinergic crisis where excess acetylcholine overstimulates all cholinergic receptors. This produces the sludge symptoms: salivation, lacrimation, urination, defecation, GI upset and emesis, plus muscle twitching and cramping. Atropine is the specific antidote because it blocks acetylcholine at muscarinic receptors, reversing the excess stimulation. It works within minutes to dry secretions, slow the GI tract, and stop the cramping. Epinephrine treats anaphylaxis, not cholinergic excess. Naloxone reverses opioids, and flumazenil reverses benzodiazepines. None address acetylcholine excess. 23. When assessing metabolic alkalosis in a patient with prolonged vomiting, which arterial blood gas finding confirms this acid-base imbalance diagnosis? A. pH below normal range. B. Increased hydrogen ions. C. pH above 7.45. D. Elevated carbon dioxide. Can you guess the answer? Correct answer, C, pH above 7.45. Explanation. Option C is correct because metabolic alkalosis from loss of gastric acid through vomiting causes pH to rise above normal range. Option A is incorrect because pH below normal indicates acidosis, not the alkalosis that results from losing stomach acid through vomiting. Option B is incorrect because increased hydrogen ions would lower pH causing acidosis, not alkalosis. Option D is incorrect because elevated carbon dioxide indicates respiratory acidosis or compensation, not primary metabolic alkalosis from vomiting. Metabolic alkalosis from vomiting creates a specific blood gas pattern we need to recognize. When someone vomits repeatedly, they lose huge amounts of hydrochloric acid from their stomach. This loss of acid leaves the body with excess bicarbonate base, shifting the pH above 7.45 into alkalosis. The blood becomes too alkaline because we've lost the acid that normally balances it. Think of it like removing weights from one side of a balance scale. The base side tips up. The body tries to compensate by breathing slower to retain CO2, which is acidic, but this compensation is limited. The key finding is that elevated pH above normal range, confirming metabolic, not respiratory, alkalosis. Treatment requires replacing lost fluids and electrolytes, especially chloride. 24. A nurse monitoring a tuberculosis patient on rifampin notices orange-tinged tears. What education should be provided about this medication side effect? A. Stop medication immediately. B. Wear glasses, not contacts. C. Increase water intake. D. Report to emergency. Do you know the answer? Correct answer, B. Wear glasses, not contacts. Explanation. Option B is correct because rifampin's harmless orange discoloration of body fluids can permanently stain contact lenses, requiring glasses during the treatment period. Option A is incorrect because orange discoloration is an expected harmless effect not requiring discontinuation of essential tuberculosis treatment. Option C is incorrect because increased water intake doesn't prevent the harmless orange discoloration that's an expected medication effect. Option D is incorrect because orange body fluids are expected with rifampin, not an emergency requiring immediate medical evaluation. The orange discoloration from rifampin is actually a reassuring sign that many patients find alarming. Rifampin, one of the core tuberculosis drugs, has a unique property where it turns all body fluids orange, including tears, urine, sweat, and saliva. This harmless colour change confirms the drug is being absorbed and distributed throughout the body at therapeutic levels. The critical issue is that these orange tears will permanently stain soft contact lenses, ruining them. While fluids help thin secretions and antibiotics treat the infection over time, positioning is the fastest intervention to improve breathing. Remember, cough suppressants are never given in pneumonia because we need the patient to cough up those infected secretions. 25. Which laboratory value in a patient with acute kidney injury indicates the most critical need for immediate dialysis to prevent life-threatening complications? A. BUN 25. B. Creatinine 1.8. C. Potassium 6.5. D. Sodium 130. Can you guess the answer? Correct answer, C. Potassium 6.5. Explanation. Option C is correct because a potassium level above 6.5 can cause fatal cardiac arrhythmias, requiring immediate dialysis to remove excess potassium and prevent death. Option A is incorrect because a BUN of 25 indicates mild azotemia, which does not require emergent dialysis compared to critical hyperkalemia levels. Option B is incorrect because a creatinine level of 1.8 indicates kidney dysfunction, but isn't immediately life-threatening, like severe hyperkalemia, which requires dialysis. Option D is incorrect because a sodium level of 130 represents mild hyponatremia, which is manageable with fluid restriction and does not require emergency dialysis intervention. Hyperkalemia above 6 is the most critical lab value in kidney injury, requiring immediate dialysis. Potassium is the electrolyte that directly controls heart rhythm, and when it rises above 6, the heart becomes electrically unstable. High potassium causes peaked T waves on the EKG, then progresses to widened QRS complexes, and finally ventricular fibrillation and cardiac arrest. This can happen within hours, making it an absolute emergency. Dialysis is the fastest way to remove excess potassium from the blood, literally pulling it out through the dialysis membrane. While elevated BUN and creatinine indicate kidney dysfunction, they don't cause immediate death. Mild hyponatremia at 130 is manageable with fluid restriction, but potassium 6.5 means imminent cardiac arrest without dialysis. 26. A patient with hiatal hernia experiences chest pain after meals. Which position modification would best prevent gastric contents from herniating through the diaphragm? A. Lying flat immediately. B. Right side positioning. C. Sitting upright after eating. D. Trendelenburg position. Do you know the answer? Correct answer, C. Sitting upright after eating. Explanation. Option C is correct because sitting upright uses gravity to keep stomach contents below the diaphragm, preventing herniation and reflux symptoms after meals. Option A is incorrect because lying flat allows stomach contents to herniate upward through the diaphragmatic defect, worsening symptoms. Option B is incorrect because right side positioning doesn't prevent upward herniation as effectively as upright positioning using gravity. Option D is incorrect because the Trendelenburg position with head down would worsen herniation by encouraging upward stomach movement. Position management is critical for hiatal hernia because gravity is our best friend. In hiatal hernia, part of the stomach pushes up through the diaphragm into the chest cavity where it doesn't belong. After eating, food and acid fill this herniated portion, causing severe heartburn and chest pain. Sitting upright after meals uses gravity to pull the stomach contents down below the diaphragm, preventing them from herniating upward. This simple position change can eliminate symptoms completely. Lying flat does the opposite, allowing the stomach to slide up through the diaphragmatic defect. Right side positioning doesn't help, and Trendelenburg position with head down would be catastrophic, pushing everything upward. Patients should remain upright for at least 3 hours after eating. 27. What respiratory pattern in COPD patients indicates hypercapnic respiratory failure requiring immediate BiPAP ventilation to prevent intubation? A. Rapid shallow breathing. B. Mental status changes. C. Productive cough increased. D. Wheezing on exhalation. Can you guess the answer? Correct answer, B. Mental status changes. Explanation. Option B is correct because mental status changes indicate carbon dioxide retention affecting brain function, requiring BiPAP to improve ventilation and prevent respiratory arrest. Option A is incorrect because rapid shallow breathing indicates respiratory distress, but not the carbon dioxide narcosis requiring immediate BiPAP intervention. Option C is incorrect because increased productive cough suggests infection exacerbation, but not the hypercapnic failure requiring ventilatory support. Option D is incorrect because wheezing indicates airway obstruction, but not the carbon dioxide retention with altered consciousness requiring BiPAP. Mental status changes are the red flag for hypercapnic respiratory failure in COPD. When COPD patients retain too much CO2, it doesn't just affect breathing, it affects the brain. Carbon dioxide crosses the blood-brain barrier and forms carbonic acid in the cerebrospinal fluid, essentially making the brain acidotic. This causes confusion, restlessness, decreased consciousness, and eventually CO2 narcosis where patients become unresponsive. These mental changes mean the patient can no longer ventilate adequately and needs immediate BiPAP support. BiPAP provides positive pressure ventilation that helps blow off the excess CO2 without intubation. Rapid breathing or increased cough don't indicate CO2 retention, like mental status changes do. Remember, when the brain shows CO2 toxicity, BiPAP is priority. 28. A patient develops tinea pedis between toes. Besides antifungal medication, which environmental modification most effectively prevents recurrence of this fungal infection? A. Wear wool socks. B. Use shared showers. C. Wear cotton socks. D. Apply moisturizer daily. Do you know the answer? Correct answer, C. Wear cotton socks. Explanation: option C is correct because cotton socks absorb moisture and allow air circulation, creating an unfavourable environment for fungal growth between toes. Option A is incorrect because wool socks retain heat and moisture, creating the warm, moist environment favourable for fungal growth. Option B is incorrect because shared showers are contamination sources for fungal spread, requiring protective footwear to prevent reinfection. Option D is incorrect because moisturizers add wetness between toes where dryness is needed to prevent fungal growth recurrence. Preventing tinea pedis recurrence requires understanding what fungi need to survive. Fungal organisms thrive in warm, moist, dark environments, exactly what's created between toes in closed shoes. Cotton socks are the key prevention tool because cotton is a natural fibre that wicks moisture away from skin and allows air circulation. This creates a dry environment where fungi cannot multiply. The breathability of cotton is critical. It lets moisture evaporate rather than trapping it against the skin. Wool socks do the opposite, retaining heat and moisture to create the perfect fungal incubator. Shared showers spread infection, and daily moisturizer adds wetness where we need dryness. Patients should change cotton socks daily and let feet air dry completely. 29. During acute cholecystitis with right upper quadrant pain radiating to shoulder, which dietary trigger should patients permanently avoid post-recovery? A. Lean protein sources. B. Fatty fried foods. C. Complex carbohydrates. D. Fresh vegetables. Can you guess the answer? Correct answer, B. Fatty fried foods. Explanation: option B is correct because fatty fried foods trigger gallbladder contraction, causing pain and potentially precipitating future cholecystitis episodes requiring permanent avoidance. Option A is incorrect because lean proteins are well tolerated and necessary for nutrition without triggering gallbladder attacks post-cholecystitis. Option C is incorrect because complex carbohydrates don't stimulate excessive gallbladder contraction and provide necessary energy without complications. Option D is incorrect because fresh vegetables provide essential nutrients and fibre without triggering gallbladder inflammation or pain. Understanding the gallbladder's response to fat explains why fatty foods must be permanently avoided after cholecystitis. When you eat fatty or fried foods, they trigger the release of cholecystokinin hormone, which causes powerful gallbladder contractions to release bile for fat digestion. In cholecystitis, these contractions push inflamed tissue and stones against the gallbladder walls, causing excruciating right upper quadrant pain that radiates to the shoulder. Even after recovery, the gallbladder remains prone to inflammation and stone formation. Each fatty meal risks triggering another acute attack. Lean proteins, complex carbohydrates, and vegetables don't stimulate these violent contractions. That's why permanent dietary modification, eliminating fried and fatty foods, is essential to prevent recurrent cholecystitis episodes. 30. Which arterial blood gas finding in an asthmatic patient indicates impending respiratory failure, requiring immediate intubation and mechanical ventilation. A. pH 7.4, B. PaCO 235, C. PaCO 265, D. PaO 295. Do you know the answer? Correct answer, C. PaCO 265. Explanation. Option C is correct because PaCO 2 of 65 indicates severe carbon dioxide retention from respiratory muscle fatigue, requiring mechanical ventilation to prevent respiratory arrest. Option A is incorrect because normal pH does not indicate the respiratory failure that elevated carbon dioxide levels would demonstrate clinically. Option B is incorrect because PaCO 2 of 35 is normal to low, indicating adequate ventilation, not requiring intubation support. Option D is incorrect because PaO 2 of 95 shows adequate oxygenation, not indicating the ventilatory failure requiring mechanical support. PaCO 2 of 65 in asthma represents impending respiratory arrest requiring immediate intubation. In asthma attacks, patients initially hyperventilate to maintain oxygenation, blowing off CO2 and creating respiratory alkalosis. As the attack progresses and airways remain constricted, respiratory muscles begin to fatigue from the extreme work of breathing. When you see CO2 rising to 65, it means the respiratory muscles are failing and can no longer maintain adequate ventilation. This is the most dangerous phase because complete respiratory muscle failure and arrest are imminent. The patient needs immediate intubation and mechanical ventilation to take over the work of breathing. Normal pH or PaO2 values don't reflect this ventilatory failure. CO2 retention is the critical marker of respiratory muscle exhaustion. 31. A cirrhosis patient with jaundice and asterixis has ammonia level of 90. Which medication dosage adjustment is indicated for optimal hepatic encephalopathy management? A. Decrease lactulose dose. B. Increase lactulose dose. C. Discontinue all medications. D. Add narcotic analgesia. Can you guess the answer? Correct answer. B. Increase lactulose dose. Explanation. Option B is correct because elevated ammonia with encephalopathy signs requires increased lactulose to promote more bowel movements, removing toxic ammonia effectively. Option A is incorrect because decreasing lactulose would reduce ammonia excretion, worsening encephalopathy when increased clearance is needed therapeutically. Option C is incorrect because discontinuing medications would eliminate the lactulose needed for ammonia removal, causing dangerous encephalopathy progression. Option D is incorrect because narcotics worsen encephalopathy by depressing mental status and slowing gut motility, reducing ammonia excretion. Lactulose dosing in hepatic encephalopathy requires careful titration based on ammonia levels and mental status. With ammonia at 90 and signs of encephalopathy like asterixis, the liver cannot detoxify ammonia to urea, causing brain toxicity. The current lactulose dose isn't producing enough bowel movements to eliminate ammonia effectively. Increasing the lactulose dose will increase bowel movement frequency, removing more ammonia through the stool. Each bowel movement literally carries ammonia out of the body before it can be absorbed. The goal remains 2 to 3 soft stools daily for optimal clearance. Decreasing lactulose would worsen encephalopathy by reducing ammonia excretion. Never give narcotics as they worsen mental status and slow gut motility, trapping more ammonia. 32. During H. pylori treatment, which medication class must be avoided due to increased risk of gastric ulceration and bleeding complications? A. Proton pump inhibitors. B. Histamine receptor blockers. C. Non-steroidal anti-inflammatory drugs. D. Antibiotic therapy combinations. Do you know the answer? Correct answer, C. Non-steroidal anti-inflammatory drugs. Explanation: Option C is correct because non-steroidal anti-inflammatory drugs inhibit protective prostaglandins in the stomach lining, increasing ulceration risk when H. pylori has already damaged the gastric mucosa. Option A is incorrect because proton pump inhibitors reduce acid production, protecting the stomach during H. pylori eradication therapy. Option B is incorrect because histamine receptor blockers reduce acid secretion, helping heal ulcers during H. pylori treatment rather than causing harm. Option D is incorrect because antibiotics are essential for H. pylori eradication and do not increase ulceration risk like non-steroidal anti-inflammatory drugs do. NSAIDs are absolutely contraindicated in H. pylori infection due to synergistic gastric damage. H. pylori bacteria burrow into the stomach's protective mucus layer, creating inflammation and ulcers by weakening the gastric defences. NSAIDs like ibuprofen and naproxen work by inhibiting prostaglandins, which are essential for producing protective mucus and maintaining blood flow to the stomach lining. When you combine H. pylori damage with NSAID-induced prostaglandin suppression, you remove all gastric protection simultaneously. This double assault dramatically increases the risk of severe ulceration, perforation, and life-threatening GI bleeding. Proton pump inhibitors and H2 blockers actually help by reducing acid during treatment. Antibiotics are essential to eradicate the infection. Only NSAIDs must be completely avoided. 33. A patient receiving isoniazid for tuberculosis reports numbness and tingling in extremities. Which vitamin supplementation prevents this peripheral neuropathy side effect? A. Vitamin C supplement. B. Vitamin B6 pyridoxine. C. Vitamin D cholecalciferol. D. Vitamin K phytonadione. Can you guess the answer? Correct answer, B. Vitamin B6 pyridoxine. Explanation: Option B is correct because isoniazid depletes vitamin B6, causing peripheral neuropathy, requiring pyridoxine supplementation to prevent nerve damage during treatment. Option A is incorrect because vitamin C doesn't prevent the peripheral neuropathy caused by B6 depletion from isoniazid therapy. Option C is incorrect because vitamin D supports bone health but doesn't address the B6 deficiency causing neuropathy symptoms. Option D is incorrect because vitamin K affects coagulation, not the nerve function impaired by B6 depletion from isoniazid. Peripheral neuropathy from isoniazid is completely preventable with vitamin B6 supplementation. Isoniazid, a critical tuberculosis drug, interferes with pyridoxine metabolism by binding to vitamin B6 and preventing its activation. Without adequate B6, nerve cells cannot produce neurotransmitters or maintain their myelin sheaths, leading to peripheral nerve damage. Patients experience numbness, tingling and burning pain starting in the fingers and toes, progressing proximally if untreated. Daily supplementation with 25 to 50 milligrams of pyridoxine prevents this entirely by providing excess B6 to overcome the drug's interference. Vitamins C, D and K don't affect nerve function or prevent isoniazid-induced neuropathy. This is why B6 is routinely prescribed with isoniazid from day one of treatment. 34. What finding during pneumonia treatment indicates development of septic shock, requiring immediate intensive care unit transfer and vasopressor support? A. Temperature 101. B. White cells 11,000. C. MAP below 65. D. Respiratory rate 20. Do you know the answer? Correct answer, C. MAP below 65. Explanation: Option C is correct because mean arterial pressure below 65 indicates inadequate organ perfusion from septic shock requiring vasopressors to prevent organ failure. Option A is incorrect because temperature 101 indicates infection, but not the hemodynamic instability of septic shock requiring ICU care. Option B is incorrect because WBC 11,000 shows mild elevation from infection, not the shock state, requiring vasopressor support urgently. Option D is incorrect because respiratory rate 20 is within normal limits, not indicating the systemic compromise of septic shock. Mean arterial pressure below 65 indicates septic shock, requiring immediate ICU transfer. MAP represents the average pressure in arteries throughout the cardiac cycle and directly determines organ perfusion. When MAP drops below 65, kidneys, brain, and other vital organs aren't receiving enough blood flow to function. In septic shock from pneumonia, bacterial toxins cause massive vasodilation and capillary leak, dropping blood pressure catastrophically. Without immediate vasopressor support to constrict vessels and restore pressure, organs begin failing within hours. Temperature of 101 and white count of 11,000 show infection, but not shock. Respiratory rate of 20 is normal. MAP below 65 is the critical value indicating hemodynamic collapse, requiring ICU-level vasopressor support to prevent death. 35. Following upper endoscopy for GERD evaluation. Which symptom requires immediate notification, as it may indicate peritonitis from perforation? A. Mild throat discomfort. B. Rigid board-like abdomen. C. Temporary voice hoarseness. D. Slight abdominal bloating. Can you guess the answer? Correct answer, D. Rigid board-like abdomen. Explanation: option B is correct, because a rigid board-like abdomen indicates peritoneal irritation from perforation, requiring emergency surgical intervention to prevent fatal peritonitis. Option A is incorrect because mild throat discomfort is expected after endoscope passage and does not indicate the serious complication of perforation. Option C is incorrect because temporary hoarseness from throat irritation is common post-procedure and does not indicate peritoneal perforation requiring surgery. Option D is incorrect because slight bloating from air insufflation during the procedure is expected, not the rigid abdomen of peritonitis. A rigid board-like abdomen after endoscopy is the hallmark sign of peritonitis from perforation. During upper endoscopy, the scope can rarely perforate the esophagus or stomach wall, creating a hole that allows gastric contents to leak into the peritoneal cavity. These acidic contents cause severe chemical irritation of the peritoneum, triggering intense inflammation. The abdominal muscles respond with maximum contraction, creating the characteristic rigid board-like feel on examination. This is a surgical emergency because peritonitis rapidly progresses to sepsis and death without immediate intervention. Mild throat discomfort and temporary hoarseness are expected from scope passage. Slight bloating from air insufflation is normal, but a rigid abdomen means perforation has occurred, requiring emergency surgery to repair the hole and wash out the peritoneal cavity. 36. A psoriasis patient asks about trigger factors to avoid. Which factor most commonly precipitates psoriasis exacerbations requiring preventive education? A. Excessive water exposure. B. High protein diet. C. Skin trauma stress. D. Vitamin supplementation. Do you know the answer? Correct answer, C. Skin trauma stress. Explanation: option C is correct because skin trauma and psychological stress trigger inflammatory cascades, causing psoriasis flares, requiring stress management and skin protection. Option A is incorrect because water exposure typically does not trigger psoriasis, although excessive washing may dry the skin, requiring moisturizer use. Option B is incorrect because protein intake does not typically influence psoriasis activity. Stress and trauma are primary exacerbation triggers. Option D is incorrect because vitamin supplementation may actually benefit psoriasis rather than triggering flares, therefore trigger avoidance is not needed. Skin trauma and psychological stress are the primary triggers for psoriasis exacerbations. Psoriasis is an autoimmune condition where T cells attack healthy skin, causing rapid cell turnover and the characteristic silvery scales. The Koebner phenomenon means any skin trauma, from scratches to sunburn, triggers new psoriatic lesions at the injury site. Psychological stress activates the inflammatory cascade through cortisol and cytokine release, directly triggering flares. This creates a vicious cycle where visible lesions cause stress, which triggers more lesions. Stress management techniques and careful skin protection are essential prevention strategies. Water exposure and protein intake don't influence psoriasis activity. Vitamins may actually help reduce inflammation. Understanding and avoiding these triggers helps patients maintain longer remission periods. 37. When educating a patient about oseltamivir for influenza prevention after exposure, what dosing schedule should the nurse explain for prophylactic effectiveness? A. Twice daily 10 days. B. Once daily 10 days. C. 3 times 5 days. D. Every 6 hours. Can you guess the answer? Correct answer, B. Once daily 10 days. Explanation: option B is correct because prophylactic oseltamivir requires once daily dosing for 10 days after exposure to effectively prevent influenza infection development. Option A is incorrect because twice daily dosing is for active influenza treatment, not the prophylactic regimen after exposure. Option C is incorrect because this doesn't match either treatment or prophylactic dosing schedules for oseltamivir influenza prevention protocols. Option D is incorrect because every 6 hours dosing isn't the standard regimen for oseltamivir prophylaxis or treatment protocols. Oseltamivir prophylaxis requires specific dosing to prevent influenza after exposure. When someone is exposed to influenza, the virus begins replicating but hasn't caused symptoms yet. Prophylactic oseltamivir works by inhibiting neuraminidase enzyme, preventing newly formed viral particles from spreading to other cells. The key is once daily dosing for 10 days, which maintains therapeutic levels to block viral spread throughout the incubation period. This differs from treatment dosing, which is twice daily for active infection. The 10-day duration covers the entire potential incubation period, plus a safety margin. Starting prophylaxis within 48 hours of exposure is critical for effectiveness. Missing doses or stopping early allows viral replication to resume, defeating the prophylactic purpose. 38. A patient with respiratory acidosis shows pH 7.3 and PaCO 255. Which intervention most effectively reduces carbon dioxide retention? A. Oxygen at 10 litres. B. Pursed lip breathing. C. Supine flat positioning. D. Sedative administration. Do you know the answer? Correct answer, B. Pursed lip breathing. Explanation: option B is correct because pursed lip breathing creates positive pressure, keeping airways open longer, allowing more CO2 exhalation to correct acidosis. Option A is incorrect because high-flow oxygen can suppress respiratory drive in CO2 retainers, worsening acidosis rather than improving it. Option C is incorrect because supine positioning impairs diaphragmatic excursion, reducing ventilation and worsening CO2 retention, causing acidosis. Option D is incorrect because sedatives depress respiratory drive, further increasing CO2 retention and worsening respiratory acidosis dangerously. Pursed lip breathing is the most effective intervention for respiratory acidosis with CO2 retention. When pH is 7.3 and PaCO2 is 55, the patient has too much carbon dioxide, causing dangerous acidosis. Pursed lip breathing works by creating positive end expiratory pressure, like breathing out through a straw. This back pressure keeps small airways open longer during exhalation, allowing more CO2 to escape with each breath. It's a technique patients can do immediately without equipment. High-flow oxygen would suppress respiratory drive in CO2 retainers, worsening acidosis. Supine positioning impairs diaphragm movement, reducing ventilation. Sedatives depress breathing, increasing CO2 retention further. Pursed lip breathing directly addresses the problem by improving CO2 elimination naturally. 39. Which skin cancer type presents as irregular lesions with various colour hues requiring immediate biopsy due to high metastatic potential? A. Basal cell carcinoma. B. Squamous cell cancer. C. Malignant melanoma. D. Actinic keratosis. Can you guess the answer? Correct answer, C. Malignant melanoma. Explanation: option C is correct because melanoma presents with irregular borders and multiple colours, having the highest metastatic potential, requiring urgent evaluation and treatment. Option A is incorrect because basal cell carcinoma appears as waxy nodules with pearly borders, rarely metastasizing, unlike aggressive melanoma. Option B is incorrect because squamous cell presents as scaly, rough lesions, having less metastatic potential than melanoma requiring biopsy. Option D is incorrect because actinic keratosis is a precancerous lesion, not the highly metastatic melanoma with colour variation. Melanoma is the deadliest skin cancer due to its aggressive metastatic behaviour. Melanoma arises from melanocytes, the pigment-producing cells, and presents as irregular lesions with multiple colours including black, brown, blue, red or white areas. The ABCDE criteria help identify it: asymmetry, border irregularity, colour variation, diameter over 6 mm, and evolution or change. What makes melanoma so dangerous is its ability to metastasize rapidly through lymphatics and bloodstream to brain, lungs, liver and bones. Even small melanomas can spread systemically before diagnosis. Basal cell carcinoma rarely metastasizes despite being most common. Squamous cell has some metastatic potential, but much less than melanoma. Early detection and immediate biopsy are critical because melanoma's prognosis depends entirely on catching it before metastasis. 40. A nurse prepares potassium replacement for a patient with a level of 2.8. What maximum hourly rate ensures safe administration? A. 40 mEq/hour. B. 20 mEq/hour. C. 60 mEq/hour. D. 5 mEq/hour. Do you know the answer? Correct answer, B. 20 mEq/hour. Explanation: option B is correct because the maximum safe potassium infusion rate is generally 10 to 20 mEq/hour to prevent cardiac arrhythmias from rapid potassium shifts. Option A is incorrect because 40 mEq/hour exceeds safe infusion rates, potentially causing fatal cardiac arrhythmias from rapid replacement. Option C is incorrect because 60 mEq/hour dangerously exceeds maximum rates, which could cause cardiac arrest from excessive potassium administration speed. Option D is incorrect because 5 mEq/hour is unnecessarily slow for symptomatic hypokalemia, when 20 mEq/hour safely corrects the deficiency. Potassium replacement requires strict rate limits to prevent cardiac arrhythmias. With potassium at 2.8, the patient needs replacement to prevent dangerous arrhythmias, but the infusion must be carefully controlled. The maximum safe rate is 10 to 20 milliequivalents per hour because potassium directly affects cardiac electrical conduction. Infusing faster causes localized hyperkalemia at the heart, triggering ventricular arrhythmias or cardiac arrest even though total body potassium is low. Think of it like pouring hot water into a cold glass too quickly. It can crack. The heart needs time to equilibrate potassium levels gradually. 40 or 60 milliequivalents per hour would cause immediate cardiac arrest. 5 is unnecessarily slow and 20 safely corrects the deficiency. Always use an infusion pump never IV push. 41. What clinical finding differentiates chronic bronchitis from emphysema in COPD assessment, requiring different management approaches for optimal outcomes? A. Barrel chest development. B. Pursed lip breathing. C. Chronic productive cough. D. Tripod positioning. Can you guess the answer? Correct answer. C. Chronic productive cough. Explanation. Option C is correct because chronic bronchitis is characterized by a persistent, productive cough with mucus, a feature less prominent in emphysema, thus influencing treatment strategies. Option A is incorrect because barrel chest is more typical of emphysema due to air trapping, rather than chronic bronchitis. Option B is incorrect because pursed lip breathing is more associated with emphysema as a compensatory mechanism to increase airway pressure. Option D is incorrect because tripod positioning is commonly seen in emphysema to aid in breathing, not specifically in chronic bronchitis. To differentiate chronic bronchitis from emphysema, we need to understand their distinct presentations. Chronic bronchitis is characterized by inflammation and excessive mucus production in the bronchi, leading to the hallmark chronic productive cough, with copious sputum production for at least 3 months per year. These patients are called blue bloaters because they retain CO2, causing cyanosis, and often have fluid retention from right heart failure. In contrast, emphysema patients have minimal cough because their problem is alveolar destruction, not mucus production. They maintain pink colour through increased respiratory effort and develop barrel chest from air trapping. The chronic productive cough specifically identifies chronic bronchitis, requiring different treatment approaches focusing on secretion management versus the breathing techniques needed for emphysema. 42. During acute myasthenia gravis crisis, which intervention takes priority to prevent respiratory failure from progressive muscle weakness? A. Administer pyridostigmine dose. B. Maintain patent airway. C. Provide small meals. D. Apply eye lubricants. Do you know the answer? Correct answer. B. Maintain patent airway. Explanation. Option B is correct because airway maintenance takes priority, as respiratory muscle weakness in myasthenic crisis can rapidly progress to respiratory failure. Option A is incorrect because medication administration is secondary to securing the airway when respiratory muscles are failing acutely. Option C is incorrect because nutrition is important, but not the immediate priority when airway compromise threatens life immediately. Option D is incorrect because eye care prevents corneal damage, but doesn't address the life-threatening respiratory muscle weakness. During myasthenic crisis, airway management takes absolute priority over everything else. Myasthenia gravis causes antibodies to destroy acetylcholine receptors at the neuromuscular junction, progressively weakening all skeletal muscles, including the diaphragm and intercostal muscles needed for breathing. In crisis, these respiratory muscles fail rapidly, and patients can lose their airway within minutes. The ability to protect the airway and breathe must be secured first because without oxygen, nothing else matters. Pyridostigmine can wait because medication won't help if the patient can't breathe. Small meals and eye care are important for long-term management, but irrelevant if respiratory failure occurs. Remember the ABCs? Airway always comes first, especially when respiratory muscles are failing. 43. Which intervention for a patient with Crohn's disease experiencing frequent diarrhea and malabsorption best maintains nutritional status during exacerbation? A. High fibre supplements. B. Large protein meals. C. Lactose-containing products. D. High calorie, low fibre. Can you guess the answer? Correct answer. D. High calorie, low fibre. Explanation. Option D is correct because a high calorie, Low-fiber diet provides necessary nutrition while minimizing intestinal irritation and diarrhea during inflammatory exacerbations. Option A is incorrect because high fiber increases intestinal motility and irritation, worsening diarrhea during Crohn's disease flares. Option B is incorrect because large meals overwhelm the inflamed intestine when small, frequent meals are better tolerated nutritionally. Option C is incorrect because lactose often worsens diarrhea in inflammatory bowel disease, requiring lactose-free alternatives during exacerbations. Managing Crohn's disease exacerbations requires balancing nutrition with intestinal rest. During flares, the inflamed intestinal walls are hypersensitive to mechanical stimulation from food passage. High-calorie, low-fiber diet provides essential nutrition for healing, while minimizing mechanical irritation that triggers cramping and diarrhea. Low fiber means less bulk moving through the inflamed intestine, reducing friction and allowing the mucosa to heal. The high calories are crucial because malabsorption and increased metabolic demands from inflammation create significant nutritional deficits. High fiber would scrape against ulcerated areas, causing pain and bleeding. Large meals overwhelm the compromised intestine. Lactose frequently isn't digested properly during inflammation, worsening diarrhea. Small, frequent, high-calorie, low-fiber meals optimize nutrition while minimizing symptoms. 44. A patient on ethambutol for tuberculosis reports color vision changes. What action should the nurse take regarding this adverse effect? A. Continue medication unchanged. B. Report to provider immediately. C. Increase vitamin intake. D. Reduce dose independently. Do you know the answer? Correct answer, B. Report to provider immediately. Explanation. Option B is correct because vision changes with ethambutol indicate potential optic neuritis, requiring immediate provider notification for dosage adjustment or discontinuation. Option A is incorrect because continuing medication with vision changes risks permanent optic nerve damage, requiring immediate intervention instead. Option C is incorrect because vitamins do not prevent ethambutol's optic toxicity when medication adjustment or discontinuation is needed urgently. Option D is incorrect because nurses cannot independently adjust tuberculosis medications when provider evaluation of toxicity is required immediately. Understanding safe foods for celiac disease requires knowing exactly what contains gluten. Celiac disease is an autoimmune condition where gluten proteins found in wheat, barley, and rye trigger the immune system to attack the small intestine lining. The drug accumulates in the optic nerve tissues, disrupting mitochondrial function and causing inflammation that affects color discrimination first, then visual acuity. Red-green color blindness is often the earliest sign, followed by decreased visual sharpness and potential complete vision loss. This toxicity is dose-dependent and usually reversible if caught early, but becomes permanent with continued exposure. The provider must be notified immediately to assess whether to reduce the dose or discontinue ethambutol entirely. Never continue the medication or adjust doses independently when vision is at stake. 45. Which assessment finding in a hepatitis patient indicates progression to liver failure, requiring immediate intervention to prevent hepatic encephalopathy? A. Clay-coloured stools. B. Dark amber urine. C. Elevated bilirubin levels. D. Ammonia level 90. Can you guess the answer? Correct answer, D. Ammonia level 90. Explanation. Option D is correct because elevated ammonia indicates the liver's inability to detoxify, causing encephalopathy requiring lactulose administration to prevent coma. Option A is incorrect because clay-coloured stools indicate bile obstruction, but not the acute encephalopathy risk of elevated ammonia. Option B is incorrect because dark urine shows bilirubin excretion, but doesn't indicate the encephalopathy risk requiring immediate intervention. Option C is incorrect because elevated bilirubin causes jaundice, but ammonia elevation specifically causes the dangerous encephalopathy complication. Ammonia level 90 indicates impending hepatic encephalopathy requiring urgent intervention. In liver failure, the damaged liver cannot convert toxic ammonia to harmless urea through the urea cycle. Ammonia then crosses the blood-brain barrier, disrupting neurotransmitter function and causing confusion, asterixis, flapping tremor, and eventually coma. This is the most dangerous acute complication of liver failure because it progresses rapidly to life-threatening cerebral edema. Lactulose must be given immediately to acidify the colon, trapping ammonia for excretion before it reaches the brain. Clay-coloured stools and dark urine indicate bile flow problems but aren't immediately life-threatening. Elevated bilirubin causes jaundice, but doesn't directly affect brain function like ammonia does. Only elevated ammonia threatens immediate neurological deterioration. 46. A patient with gallstones experiences sudden right upper quadrant pain after eating fried chicken. What complication does fever with this presentation indicate? A. Acid reflux disease. B. Acute cholecystitis inflammation. C. Peptic ulcer perforation. D. Pancreatitis development. Do you know the answer? Correct answer, B. Acute cholecystitis inflammation. Explanation. Option B is correct because fever with right upper quadrant pain after eating fatty foods indicates gallbladder inflammation from stone obstruction, requiring antibiotics and possible surgery. Option A is incorrect because acid reflux causes heartburn without fever and does not specifically worsen with fatty food ingestion. Option C is incorrect because peptic ulcer perforation causes sudden generalized abdominal pain with peritonitis, not localized right upper quadrant pain. Option D is incorrect because pancreatitis causes epigastric pain radiating to the back, not the specific right upper quadrant pain of cholecystitis. Fever with right upper quadrant pain after fatty foods confirms acute cholecystitis inflammation. When gallstones block the cystic duct, bile becomes trapped in the gallbladder, creating a perfect environment for bacterial growth and inflammation. The fever specifically indicates that simple biliary colic has progressed to acute cholecystitis with active inflammation or infection. This combination of fever, severe RUQ pain, and recent fatty food intake forms the classic triad for cholecystitis diagnosis. The inflammation causes the gallbladder wall to thicken and become friable, risking perforation if untreated. Antibiotics must be started immediately, and surgical removal is often needed within 72 hours. Without fever, it might just be biliary colic. The fever changes everything, indicating inflammation requiring urgent treatment to prevent complications like gangrene or perforation. 47. When caring for a glaucoma patient using pilocarpine drops, what side effect requires safety precautions due to vision changes? A. Pupil dilation. B. Corneal clouding. C. Meiosis constriction. D. Lens yellowing. Can you guess the answer? Correct answer, C. Meiosis constriction. Explanation. Option C is correct because pilocarpine causes pupillary constriction, reducing light entry and peripheral vision, requiring safety measures to prevent falls. Option A is incorrect because pilocarpine causes constriction, not dilation. Mydriatic drugs cause the pupil dilation effect instead. Option B is incorrect because corneal clouding isn't a pilocarpine effect when meiosis and decreased vision are the concerns. Option D is incorrect because lens yellowing indicates cataracts, not the pupillary constriction effect of pilocarpine requiring precautions. Pilocarpine causes meiosis, which significantly impacts vision and safety. Pilocarpine is a cholinergic drug that stimulates muscarinic receptors in the eye, causing the pupillary sphincter muscle to contract. This creates meiosis, meaning severe pupillary constriction that can reduce the pupil to pinpoint size. With such a small pupil, less light enters the eye, dramatically reducing vision, especially in dim lighting. Peripheral vision is also severely limited because the constricted pupil restricts the visual field. This creates major safety concerns for activities like driving, navigating stairs, or moving in low-light conditions. Patients often describe it like looking through a tunnel. The effect lasts several hours after each dose, requiring patients to plan activities around their dosing schedule and take extra safety precautions. 48. What laboratory finding indicates therapeutic effectiveness of rifampin in tuberculosis treatment despite alarming appearance to patients? A. Decreased white cells. B. Orange body fluids. C. Elevated liver enzymes. D. Low platelet count. Do you know the answer? Correct answer, B. Orange body fluids. Explanation: option B is correct because orange discoloration of body fluids confirms rifampin absorption and therapeutic levels, though the alarming appearance requires patient education. Option A is incorrect because decreased white cells would indicate bone marrow suppression, an adverse effect, not therapeutic effectiveness. Option C is incorrect because elevated liver enzymes indicate hepatotoxicity, requiring dose adjustment, not therapeutic effectiveness. Option D is incorrect because low platelets suggest adverse effects, not the therapeutic drug levels indicated by orange discoloration. Orange body fluids from rifampin actually confirm therapeutic drug levels. This unique side effect occurs because rifampin is metabolized into colored metabolites that distribute throughout all body fluids, including tears, urine, sweat, and saliva. The orange discoloration is proof that rifampin is being absorbed from the gut, processed by the liver, and distributed systemically at levels needed to kill tuberculosis bacteria. It's like a built-in indicator that the medication is working properly. This is completely different from adverse effects like decreased white cells indicating bone marrow suppression, elevated liver enzymes showing hepatotoxicity, or low platelets suggesting bleeding risk. The orange colour is harmless and expected, reassuring both patient and provider that therapeutic levels are achieved. It disappears completely after finishing the treatment course. 49. A patient with pleural effusion undergoes thoracentesis. Which post-procedure finding requires immediate intervention, suggesting pneumothorax development? A. Mild insertion discomfort. B. Asymmetrical chest expansion. C. Clear breath sounds. D. Improved oxygen saturation. Can you guess the answer? Correct answer, B. Asymmetrical chest expansion. Explanation: option B is correct because asymmetrical chest expansion indicates pneumothorax from lung puncture during thoracentesis requiring chest tube placement to re-expand lung. Option A is incorrect because mild discomfort at insertion site is expected after needle insertion, not indicating pneumothorax complication. Option C is incorrect because clear breath sounds indicate successful fluid removal and lung re-expansion, not pneumothorax development. Option D is incorrect because improved oxygenation shows successful effusion drainage when pneumothorax would worsen oxygen saturation instead. Asymmetrical chest expansion after thoracentesis signals pneumothorax requiring immediate intervention. During thoracentesis, a needle is inserted through the chest wall to drain pleural fluid. If the needle accidentally punctures the lung tissue, air escapes into the pleural space, creating a pneumothorax. This destroys the villi that absorb nutrients, causing malabsorption and diarrhea. Corn is completely safe because it's a gluten-free grain that doesn't contain the problematic proteins. Cornflakes made from pure corn provide a nutritious breakfast option without triggering intestinal damage. Immediate chest tube placement is needed to evacuate the air and re-expand the lung. Mild discomfort is expected from the needle insertion. Clear breath sounds and improved oxygenation indicate successful fluid drainage, not complications. 50. Which dietary modification most effectively prevents symptom recurrence in patients recovering from acute diverticulitis after inflammation resolves? A. Low residue diet. B. Clear liquid only. C. High fiber intake. D. Protein restriction. Do you know the answer? Correct answer, C. High fiber intake. Explanation: option C is correct because a high fiber diet after the acute phase prevents constipation and reduces intraluminal pressure, preventing future diverticulitis episodes. Option A is incorrect because a low residue diet is used during acute inflammation, but high fiber prevents recurrence after recovery. Option B is incorrect because clear liquids are for the acute phase, while a high fiber maintenance diet effectively prevents future episodes. Option D is incorrect because protein restriction is not indicated when adequate protein supports healing, and fiber prevents recurrence. High fiber intake after diverticulitis recovery is essential for preventing recurrence. During acute diverticulitis, inflamed diverticula need rest, so we use low residue diets. But once healed, the strategy completely reverses. High fiber adds bulk to stool and helps it move smoothly through the colon, preventing the constipation and straining that increase intraluminal pressure. This pressure is what causes diverticula to form and become inflamed in the first place. Think of fiber as nature's pressure relief valve for the colon. Without adequate fiber, hard stools require forceful contractions to move, creating high pressure zones that blow out weak spots in the colon wall. 25 to 35 grams of fiber daily keeps stool soft, reduces colonic pressure, and prevents future diverticular inflammation. You have reached the end of our first question set. For the free complete exam preparation, visit our website link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.